Okay, so hello and welcome everyone. Today, India's digital health space is moving fast, and the questions it raises are as human as they are technical. So, to understand it better, today we have Dr. Vibha Jain, who is a clinician and the founder of Hiravika. So, good afternoon, Dr. Jain. It's a pleasure to have you with us today.
Good afternoon, Pinaki.
Uh, Thank you. So before we dive into like very important and very technical stuff like ABDM and UHI, let's just first ask Dr. Jain about after working for almost like 3 decades in the industry, what made you feel something was broken in the system? Or what made you transition from a clinical role to system strengthening or consulting?
Um, uh, Good afternoon, Pinaki, and thanks a lot for having me here. It's always pleasure to talk to the team, to contribute in whichever way I can. But to answer your question, as you rightly mentioned, when I passed out as a fresh graduate out of the medical college, right, I had dreams in my eyes, hoping to change the way the healthcare delivery is done and I mean, not what not to do. But as I started practicing and as I started getting more practical views while practicing in this particular field, uh, I got aware of the complexities and various variables which operate, right? It's not as simple as getting a patient, treating that particular patient, prescribing certain medicines, that patient going home, or like performing a surgery. It's more than that, right? It's about the whole ecosystem, how that particular ecosystem works, and that is more important uh, factor when you talk about systems, right? That was something which I felt at that particular time, that the systems, there are gaps. I would not say that systems are bad, but I could see there were gaps. Things were not continuous. They were like kind of staggered, right? And I was always on the lookout of how can we plug those particular gaps. And that was the one major reason I ventured into the other side, which was adopting technology. India has seen, I have been fortunate enough to be at that particular juncture when India's healthcare was venturing from that conventional mode of practicing towards that automated, digitalized, and all those kind of stuff. And they are very fancy stuff, right? Uh, we'll automate the system, we'll make the lives of doctors better, we'll make the lives of patients better. Easier said than done. So over 3 decades, I've seen transitioning of that particular system. Still, a lot needs to be done because it's not only about features, it's not only about plugging those gaps. There has to be certain continuity, and that can only come when the whole system or the whole ecosystem works as one, imbibing all the complexities, all the variables, all the differences which are there in the clinical practices in India. That's what I've been observing. And there has been an evolution of ABDM now, right? And I think that's the bigger vision of the government, moving towards that unified health for all, as we say. India as an ecosystem is a very unique health ecosystem, I would say. So we have private players, we have government organizations, we have government hospitals, there is a rural areas, there are urban areas, there are semi-urban areas, all these kind of stuff. It's very difficult to find out all these things in any other healthcare system in the world. So we have everything here in India. So the opportunity is big, but yes, at the same time, the challenges are also big.
Yeah, so it's like the systemic gaps that still need to be looked after, and we
Yeah,
need much more than clinical knowledge for that. So,
exactly,
like, yeah,
exactly.
so let's move to our formal FAQ session. Let's talk about the buzzword first, AI. So, I really wanted to talk to you about AI validation and governance, since most of the clinical AI is currently trained on Western data sets like UK,
Hmm.
Biobank, etc. So there is a significant risk of distributional shift when applied to
Hmm.
the Indian population. So,
Hmm.
if I ask you, ABDM Sandbox solves that bias of the Western trained AI in India. If it does, so how efficient it is in that way. Plus the urban hospitals in India, if we look at the situation within the country, most of the data
Mhm.
in India itself comes from the urban and the tertiary level hospitals. So then again, there is a gap between the urban and the rural data set. So how do we
Mhm.
fix that as well? So these are like the two questions I would like you to answer.
So, Binaki, as you rightly said, the whole buzzword of AI that is dependent upon the data set on which that particular algorithm or that model has been trained on. And fortunately, unfortunately, we do not have that kind of data sets which are available uh, in the Indian context. So, first and foremost thing probably would be whatever AI models that have been trained on the international data, right? They need to be contextualized to the Indian markets, to the Indian data sets. ABDM does provide the sandbox. It does provide some kind of a data set, but that data set, uh, I'm not sure how inclusive that data set is, right? I mean, it's good to have something rather than nothing. So yes, it is the step in the right direction that sandbox is now available for the companies to train their AI data models on. But then we need more than that actually. Reason being, uh, within an interoperable ecosystem like ABDM, governance is the key thing. It's not only about the availability of data, but also on the governance of how that particular data is getting used, right? So I would say there would be four key pillars which will help in that interoperable ecosystem like the ABDM. One is your local clinical validation, right? All AI models, they need to be tested on representative Indian data sets across demographics, across regions and levels of care. They should also be tested not only for the accuracy, but the bias or explainability or the incomplete records which are available in the Indian data sets, right? The second thing is the risk-based regulatory oversight. There are AI applications which impact diagnosis or the triage or the treatment decisions. They need to be classified as high risk data sets, right? So we cannot like label all the data sets as normal data sets. There has to be some kind of a categorization which will help us in demarcating a risk level or a risk in the scalability which can come by using that particular data. The third thing would be interoperability. Yes, that is something which we need, but then with that, there has to be some accountability, right? In ABDM enabled environments, accessibility to the data does not mean that unrestricted data is available to everyone. There has to be some kind of a control. There has to be some kind of a consent driven data exchange or traceable audit logs like that, so as to ensure accountability across the systems and the stakeholders. And the fourth most important thing in my mind would be continuous monitoring and revalidation. So it is not that once you've done a kind of a validation of the AI model today, that approval should not go beyond a certain point. There has to be a continuous validation process. They should go continuous deployment monitoring for any drift, for any unintended outcomes, and evolving population health threats. Right? So there has to be some periodic recalibration and certification renewal for that. To me, India right now has an opportunity to create a globally relevant governance model. Uh, they have a very good public infrastructure, but that has to be combined with a what do you say responsible AI principles. The for the clinically safe and equitable AI adoption. That's what I feel.
Okay, so that brings us to again, a very important point. Like now we're talking about data sets. So they are very sensitive pieces of information, right? So let's talk about the safety and equity part of it. So like clinical AI deployment isn't just like a technical challenge, it
Mhm.
also has an equity factor attached to it. So especially like if you're talking about a country like India where the digital divide and the language diversity is so huge. So if you learn from the cautionary tales like IBM
Mhm.
Watson for oncology, how do we design like a post-market surveillance, like something similar to pharmacovigilance, to catch the failures in real time? Also, like try to shed some
Mhm.
light on explainable AI, XAI, like if possible.
Um, when you say about something like creating vigilance around that AI, right? Something like a pharmacovigilance you're talking about, right? Uh, when you talk of AI models, I must say at this particular moment, though that's a buzzword in India right now, in the healthcare system, everybody's talking of it, but still, it's far from getting done. So the first thing which the companies or the people who are wanting to train their AI models on are facing is the scarcity of the data set, as we know. Once they get it even, there are no regulations in place, right? Though we are having those kind of DPDP Act which are coming in, but still, uh, when you talk of any authority which is keeping a track of it, it's still basis that localized company who's creating that AI model. So it becomes a prerogative of that particular company that they are putting up the right vigilant or right access control or the right security features in their system or not. Somebody like me who's at the other end, who's going to utilize it, we'll ask certain questions from them, right? I'll ask him, have you put it in this place? They'll provide me certain certificates, or they'll provide, I put it on a server which is known to have all the security features in place. That's the maximum we are going to do. But then when you talk of a central authority monitoring those things which are happening in this Indian healthcare space, there's a scarcity of that. So when we are talking about an interoperable system like that, when you're talking of a big term like a pharmacovigilance, I must say for AI, that is something just still, maybe it is in progression. We don't know of it, but at the front of it, it is not visible, right? So there needs to be, there is something which needs to be done a lot in this particular area because AI comes with its own responsibility, especially when you're when you're using your AI models, for which purpose that data is getting utilized. You have to categorize those particular things because then only you will be able to categorize the AIs or the models or the outputs into certain categories itself. For example, if there is an AI model which is helping you in uh, doing the diagnosis, it is helping you in triaging of the systems, or it is helping the doctors in taking the treatments, right? That is a high risk thing in itself, which needs a human validation. Fair enough. This data set cannot be compared to when you are talking of predicting how the appointments are going to come, how is the patient footfall going to be there. That kind of a predictive model, if you're doing that, that's a low risk. I mean, it's a risky thing because the personal information of the patients is there. But then, as compared to this particular data set, that's not a that much of a risky thing. So, in that particular case, what happens is when you're creating a vigilant system for these models, that has to be taking care of all this thing. Plus, the other thing which needs to be there has to be always a human in the loop. There has always to be a consent based system in place, right? There has to be design, a privacy design, which is privacy element, which is in the design of that particular product. It cannot happen like that. You have created a model, and after creating the model, you're thinking, oh, I have to now introduce these things. It has to be a system design thinking, which starts from the time you're thinking of actually deploying an AI model. That's what I must say about that vigilance part of the thing which you talked about.
Okay, so all these like technical jargons, they seem so new, but at the same time so intimidating, especially for people who have always worked with let's say paper prescriptions and manual documentations. So for them, it's like it's a new world altogether. So
Hmm.
even if like nowadays, if we talk about making simple payments through UPI apps. So it's so the monetary transactions have become so easy, so smooth. And talking of which, it reminds me of my next question. So I wanted to ask you about UHI protocols. So UHI is like
Hmm.
UPI but for healthcare, right? And the problem is a failed health record is like way more dangerous than a failed payment, let's say. So, do you think
Hmm.
like the current consent artifact model that we have, it really works when a patient moves between multiple doctors. It's like who is legally liable if the data transfer fails or is incomplete.
So it's again a gray area right now, Pinaki. I must say that, right? In UPI, the things, and I would say in terms of the financial transactions, even in the hospitals also, right? When you are having those kind of transactions, it's a very clear picture, 0 or 1 kind of a thing, right? You made a payment, either it gets accepted or it fails. If it fails, the bank will tell you that it has failed. You please make the payment again. Sometimes they have received the payment, but it is like not correct or whatever. They'll return the amount to you. Fine. In healthcare, it doesn't happen like that, right? I have shared the data, you got it, or you did not get it. But then it's not only that data. We are actually talking about shared pathways and the information which is going around that. It's not a quantifiable as a data, but information which is there, it's not as simple as a 4 rupee or a 2 rupee. That 4 rupee might be a 400, it might be -4, it might be 4,000 also. So in that particular case, what becomes important is the chain where that particular data is stored and how that chain is getting maintained and who is the owner of that particular packet or that block when that data is getting transferred. So patient comes into the hospital, the whole responsibility of that patient lies on the doctor. Fine. If there is any AI algorithm which is getting used because the hospital has decided to use it, again coming back to the same two things which I repeated earlier, who you have to have a human in the loop who is then authorizing what is actually happening to that particular AI model. The second thing is the patient. When you're talking about patient, has he given the consent to it to use his data? So when you're talking of the UHI kind of a thing, yes, it is not that it is not possible, but the variables around it are have to be factored in, and there have to be proper controls at each level so that when you go for that UHI, I hope it is like unified health interface we are talking about. When we go to that particular level, everything is very clearly defined. The accountability sets are clearly defined. How much data is exposed to which person, right? Everybody does not need the same kind of access of that data. So a doctor would need more details as compared to a care coordinator who's just putting an appointment of the patient, right? So these all factors. I mean, I am not talking of if we start talking, I think ये topic अपने आप में बहुत बड़ा हो जाएगा. It's a very big thing in itself. But अगर उसको if I try to capsulize it, if I try to kind of bring it into 2 or 3 particular points, I think one thing definitely would be there. One thing is there has to be clinical context beyond simple data exchange, right? It cannot operate as a purely transactional system as we talked about. The second thing is clear liability and accountability framework. I've already spoken about it. Obviously, the third important thing is about the dynamic and informed consent architecture. You must be knowing, आज की तारीख में भी whenever a patient goes to a hospital, there is a broad consent we already take from that particular patient. We'll be sharing your data or whatever it is. But then our responsibility doesn't end there. There has to be informed consent at every step wherever you are using that particular data. And when you're collecting that data, that has to be also categorized for which that particular data is getting used. Is it going to be used for a research or is it a like kind of a transactional data you're capturing? And the fourth most important point from my perspective would be embedded safety and quality standard, which I told you in the first thing. That whatever mechanism or whatever workflow or whatever governance system is there, those safety principles, those audit principles, those consent mechanism principles, they have to be embedded within that particular design. So what we need to do from our side, जो हम लोग बैठे हुए हैं, we need to have that kind of a thinking that whenever we design any product, whenever we design any pathway, whenever we design any care model, those particular elements, they are embedded within. We don't have to like think it as a separate item or a separate category. Those are the things which are the essential blocks of creating that particular pathways for us.
Okay, so you
That's what
mentioned a very interesting part where you said that who the data should be exposed to. Like a person who's sitting at the, let's say, the hospital reception, they don't need to know what your mental health illness is. And
Right.
talking, yeah, and speaking of which, if we talk about very sensitive domains like mental health itself, so
Mhm.
again, like if we talk about India, mental health data carries like a unique structural risk in India. Like a breach of mental health illnesses can impact a lot of things: marriage prospects, employment, child disputes, property disputes, all of these things. So if we look at the strict privacy restrictions we have got under the MHA 2017, should these records be kept in a separate silo that patient must manually unlock, like they have the access to it whenever they want to? Or how do we balance like keeping the patient safe from the stigma that's come with it, while also ensuring that the doctor have enough information to treat them? Like doctor has like ample of information to treat that patient, but the authority of the data is stays with the patient himself.
So, coming back to this particular question, also, if we keep in mind the things which we have spoken about Abibi already, right? The first and foremost thing, and when we talk of India, right, mental health is a taboo everywhere. It's not something which is simple. But when it comes to India, talking about mental health is a stigma, and the people who are correcting is that is also like you getting mushroom health psychologists these days, right? Behavioral people and all those kind of thing. And this particular thing is such that I will talk to the person whom I can connect with. I'm not looking for a person who is qualified or not, but I'll talk to a person with whom I'm connected with. So that's a given kind of advent to the new apps which have come up in the market. You must have seen those, right? When we talk of India as a whole, and when we are talking of something like an ABDM, which are which is wanting to create a health fiduciary of its own, the health data of the Indian citizen, right? And there is a mental health data of that person. The best way, in my mind, would be to categorize the data which is getting collected into certain categories. As you say of the documents, right? You know there are certain classified documents. There are documents which are available for the RTI. There are documents which are available in the public domain. Same way, there's a data. You have to do a categorization of the data. So a mental health data is a highly classified kind of a data, which can be accessed only by the people who are allowed to view that data. Maybe it is a person, the doctor who is treating that particular patient, and the patient himself or herself. Because as a patient, if I have disclosed my data to you, for example, I might like it to disclose it to somebody else also. So when you are categorizing or when you're storing that particular data in the system, you have to have a mechanism wherein you can classify that data as a classified data, bounded by access controls, bounded by consent mechanism, which is a layer above. So you have a tiered consent-based consent system, wherein a little bit of is accessible to everyone, but the highly classified things are accessible only to the patient and the treating doctor. That way, this mental health data, because what is important also for the people or the patient is to have the trust in the system. Unless and until they know that the system is trustworthy, this is transparent, there are enough governing principles in place which makes sure that my data is not going to be shared with anybody except me or my doctor, and that too with my consent only. That kind of trust would come only when the system is made with this particular mindset in there, and that is designed to create that kind of a trust and transparency within the system, within the patients. Otherwise, what will happen is there will be certain breaches. I would not say that you've created a very 100% secure system. There would not be breaches at all. But yes, they would know that if there is a breach, we will know how to catch that particular person and how to contain that particular breach. So it is not only about uh, kind of securing the data or creating that categorization or the highly classified thing, but also maintaining a kind of, as you said, a vigilant system, which is there to keep all these malpractices which can happen. Keep a check on those malpractices which can happen, right?
So all these aspects have to be well intertwined in order to make like a very strong system where nothing leaks out and everything is so streamlined and along with the integrity of the data because it's so important. These things are very sensitive. So
Easier
like
said than done than said. Easier said than done, Pinaki. Because what I've observed is, look, in India, your data is everywhere. Okay, your data is there in the government hospital. Your data is there in the private hospital. Your data is there in a particular nursing home. Your data is also with certain app, and to combine that data at one place, again, it's a very humongous task. But then, if you've shared your data at one time, why is there a need to share the same data again? You already have it. So there has to be, it's not about accessing the data unrestrictedly, but it is also about having access to a continuity of care. That system, it provides a continuity of care. So it's not about a continuity of the data flow, that yes, my data is flowing into different systems. The interoperability is happening, the data is flowing. No, it is not only interoperability of data, it is also interoperability of the care pathways. And once those principles or those thinking sets are put when we are making those kind of policies, when we are trying to create those kind of ecosystem, everything will fall into place. Those thinkings have to come from that particular level, that what exactly are you trying to do? And once those things come, the security, the consent, the care pathways, all these things will align. These are like simple blocks which are kind of scattered. Everybody knows about it. It's just that somebody has to think through, look, I have to create a bigger picture and those blocks have to fill in the pieces. If there is a gap, we have to fill those gaps so that everything seems a kind of a continuous model which is there. And I think that is what ABM is trying to do.
okay, so let's like now that our interview is climaxing, so let's wrap up the interview with the last question, and keeping the fact in mind that Hiravika is your brainchild. So let's talk about the DPDP Compliance Act. So health startups often face a compliance paradox. Let's say DPDP Act 2023, it mandates data minimization. Yet AI models, they require rich, high volume data sets to remain accurate in their own place, right? So how can startups balance this without thwarting innovation? How can they share the data with partners without burying their users with consent pop-ups and the consent processes?
So look, it might not feel very good to us as startups, but yes, two things, they are the principles when you're talking about data sharing or collecting, right? Meaningful consent and data minimization. However, bad I might feel about creating those pop-ups for the consent, but that is something which is to be there. Uh, when I say meaningful consent is you take the consent whenever you feel that there is something important regarding the patient data which is getting shared or used. Not that every time you throw that particular consent pop-up. The second thing which we talk about is a data minimization. Um, I would say it is something you collect only what is necessary, right? You don't need to collect all the data all the time. So whenever there is a startup, I have to have in mind, if I'm collecting any data or if I'm wanting to have some data from the user, what is that I'm going to do with that data? Why am I collecting that particular data? Where, what data I am getting, I'm collecting, or who it may be shared with, how long I have to retain that particular data, and how uh, the person will know that I have given the consent to use that particular data, but how can I withdraw that particular data? So I'll tell you a small, I think I have a little bit of time. एक छोटा सा incident आपको बता देती हूँ. We were creating a app platform for a startup, right? Advising them on that particular thing. Consent डाला, उनका काफी सारा data, and we were taking that particular data. So they were acting as aggregators also, certain. So they had third party integrations and all. We said we'll introduce that consent. The patient will be informed that your data is getting used and we'll be using it for this particular purpose. And he'll have the right to withdraw the consent anytime. So when that person withdraws the consent, that data has to be removed from everywhere in our systems. Very good. We did that. They did that. Everything was happy. I just happened to ask one question from them. Because look, this data which you have taken from the patient, one of this particular line is going to the third-party integrator who's using the data to give the plan to that particular patient. So when that person is withdrawing the consent, are you taking that data out from that particular person's application also? Or is it going to remain with the third party? Nobody thought of that. So again, the good principle. I mean, I think that is something, if everybody remembers any system you design, maybe it is a startup or a kind of a mature organization, those two things will help anyone. Data minimization, you need to understand why you're collecting that data, right? Take the consent from the patient. Be transparent. Tell that person why are you using that data. They need to know. And if they have a trust on your system, they'll definitely share data. Nobody will, like financial transactions, we do our transactions that it's like crores and crores of things, and we tell the people that the CAs know everything, right? The people who are filing the returns, they know everything. So why can't we share our health data also? But we are not able to share that because we don't have confidence in the system. Once that trust comes up, it is like going to be there. So the third thing is building privacy into the product architecture. It should not be like the compliance should not be treated as a post-launch legal exercise. Where, as I spoke before, privacy by design, जैसे role-based access हो गया, encryption हो गया, tokenized हो गया, tokenization हो गया, audit trails, and these are the principles which have to be taken care at the time of when you're creating that particular product, not at like बना लिया, अब हम सोचते हैं इसके बारे में. And the fourth most important thing is, as I said about the categorization of the data, right? High risk or low risk or something. Please separate the innovation data from the personalized patient data. We need data for innovating things, right? But that data can be anonymized. I am collecting certain information. I know I'm going to use it for innovation. I have to keep that in mind. So when I'm using it for innovation, I don't need to have any other personal identifiable information. I just need it for innovation. I need the data of say 100 people who are diabetic in this particular age group. I need their HbA1c things for the past say 2 years or 3 years. That's the only information I need. I don't need to know if it belongs to A or if it belongs to B. I need to know the age range. I need to know the gender. I need to know the values. That's it. I don't need it belongs to like say Pinaki. It belongs to Dr. Vibha. Oh, fair enough. But at the same time, when I'm talking of the app, when I'm creating, I would say, hi Pinaki, how are you today? How can I help you today? That's a different information I'm collecting. So keep these two things separate. And to my mind, as I'm talking to you, Pinaki, there are certain ideas which are coming to my mind. And as I understand, what is important is when you're collecting the data, and it's with anything, आप कर क्यों रहे हो कोई भी चीज? You need to understand the purpose of it. When you start putting your mind to that particular thing, you'll understand why you're doing this. And when you do this and keep those 2-3 principles in mind, everything will fall into place. India is at a very crucial juncture right now, and it's like kind of the opportunity which India has, which nobody else in the world has. US, the system is insured, right? You like it or don't like it, your data is with them. Fine. UK, you have NHS. European countries also, public, private, but yes, there is kind of a control on the things with the GDP. India, we have government-owned hospitals, we have private hospitals, we have private nursing homes, we have rural areas, we have semi-urban areas, we have diagnostic centers, and everybody is operating in their own way. And then we have ABDM, which is trying to unify our health, which is trying to unify our health data, right? Opportunities like kind of unlimited. What we just need to understand is that when we are trying to scale, we also need to understand that it's a care which we scale, not the risk which we scale. So we don't introduce any element that whenever we have created a system, we have introduced such a risk that when we scale, that risk is also multiplied. So consent, human in the loop, right? Categorization of the data minimization as in collect what is required, separate the data. Separate the data as in you need it for innovation or you need it for running your app. And tired consent and role-based access. These are 5-6 things. If anybody keeps in mind, I think they'll be able to make a fairly good system and able to contribute into the overall health ecosystem of India, which ABDM is driving. That's what I understand.
Okay, so thank you so much. It was such, I really wanted to talk to you about it. It's such an important and such an interesting topic. And I'm really thankful and grateful to have you with us today. And I would really want you to be a part of more such videos because this is very interesting and I really enjoy talking to you through and through.
Thank you,
Thank you.
Pinaki. I hope it helps you. It helped, and I was able to contribute. I mean, I understand there are so many things to talk about. आधी चीजें शायद मैं भूल भी गई होंगी आपको बताने के लिए. But हाँ, I remembered all the major things which were to be talked about, and always good to talk to you people. So anytime.
Okay, thank you. Thank you so much.
Thank you.